Hello. Hello, can you hear me?
Yes, sir. We are able to hear you.
Okay. Shall I share my screen?
Yes, sir. Sure, sir.
अस्सलाम वालेकुम रहमतुल्लाहि व बरकातहू।
वालेकुम अस्सलाम रहमतुल्लाहि व बरकातहू।
जी सर, वही ऑडियो चेक कर ले रहे हैं। थैंक यू।
Can you see screen? Are you able to see the slides?
Yes, slide show you are unable to see. Your entire screen is shared.
My voice is echoing actually. I'll try to log out and log in again.
Okay.
Are you able to see my screen now?
Yes, screen is seen.
Okay, thank you.
You have to put it in the slide mode.
Yeah, I'll put.
Meanwhile, we will just share the screen showing the backdrop for the program.
Okay, sure, no problem. I'll minimize it then. I'll stop sharing, right?
Yes.
Okay, fine.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Walaikum salam.
Shall we start the program?
Yes, yes.
Yeah.
Okay, so share this.
Bismillahirrahmanirrahim. Respected doctors and dear colleagues, a very warm welcome to everyone for today's CME program organized by DARE. I am Dr. Nidaullah, Assistant Professor in Government Medical College, Jatial, and I have the privilege of being the convener for today's program. We have a very interesting and academically enriching session planned for you today on the topic of movement disorders and advanced therapies. To begin the program, I would like to invite Dr. Abdul Wase for the Quran recitation and a brief introduction to DARE. Dr. Wase, over to you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Nida. So, without any further delay, أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن الله يأمركم أن تؤدوا الأمانات إلى أهلها وإذا حكمتم بين الناس أن تحكموا بالعدل إن الله نعم ما يعظكم به إن الله كان سميعا بصيرا. صدق الله العظيم. पनाह चाहता हूँ मैं अल्लाह के शैतान मरदूद के शर से, शुरू अल्लाह के नाम से जो रहमान और रहीम है. I seek refuge in Allah from shaitan and outcast, in the name of Allah, the most gracious, the most merciful. So I have selected this one particular ayat from the Surah An-Nisa, that is the ayat number 58, in which Allah subhanahu wa ta'ala says that, commands the believers, commands the people who believe in Allah and the Prophet sallallahu alaihi wasallam and the life after that, addressing them as मुसलमानों, अल्लाह तुम्हें हुक्म देता है कि अमानतें अहले अमानत के सुपुर्द कर दो और जब लोगों के दरमियान फैसला करो तो अदल के साथ करो. अल्लाह तुमको निहायत उम्दा नसीहत करता है और यकीनन अल्लाह सब कुछ सुनता और देखता है. In this particular ayat, Allah commands the believers, commands you and me to deliver trusts to those worthy of them. And when you judge between people, to judge with justice. Excellent is the admonition Allah gives you Allah is all hearing, all seeing. So in this particular ayat, we have direct command and instruction from Allah subhanahu wa ta'ala that we should be dutiful and we should consider the amanat which is given to us in the terms of accountability. As Muslims and as part of our belief, we consider Allah subhanahu wa ta'ala as our Rabb, the one who is the all sustainer, the cherisher, the sustainer, the provider. It is not just a deity worthy of worship, but in addition to that, we also believe that all the gifts, all the blessings, what all are the requirements given to us in the form of risk, in the form of knowledge, in the form of resources, in the form of people, in the form of relations, and all the feelings and the belongings what we have in this world are a blessing in the form of ni'mat given to us. And it is a kind of trust. So there is both the things. It is not only just a gift, but it is also a trust. And the concept of amanat, we bear that we own the responsibility for all the things we are blessed with in terms of the trust, the rights towards Allah, as well as the rights towards the other creations. So when it comes to our practice in our field, in our profession, we believe, as part of our belief, being a Muslim doctor, that the knowledge, the recognition, the qualification, the position in which we are is not only just a gift and a blessing, but it is also an amanat. And it demands accountability towards Allah subhanahu wa ta'ala as well as towards the other people with whom we are interacting. So this ayat instructs us that whenever we are dealing with this amanat of our profession, how we should carry ourselves, that we should be dutiful in transferring the knowledge, in transferring the skills, or in transferring the services which are required to the people who are suffering with the various conditions, who seek help from us as an amanat in the form of an act of worship towards the other people. And we should be conscious enough that we should be doing justice in that, because Allah subhanahu wa ta'ala is all hearing or listening. He even knows our intentions with what we are delivering these services. So this particular ayat is very relevant to our profession and it provides guidance to us. This should always remind us that in whatever stage of our life, with whatever condition in which we are dealing with the other people, let it be patients, our juniors, our seniors, our colleagues, our team members, that whatever we have is not just belonging to us. It is not just an achievement, but it is a blessing. And at the same time, it is an amanat for which we are accountable towards Allah as well as towards our other people also and the other creations. And that we should always keep in mind that it should be delivered with complete justice. And following this obedience, Allah subhanahu wa ta'ala says that this instruction which is given to us, that be dutiful and amanaton ka lihaz rakhna hai, this is an excellent advice, this is an excellent instruction. And Allah subhanahu wa ta'ala indirectly conveys to the believers that excellence is expected from all of you, but at least don't do injustice. Always be mindful of the justice in delivering the amanat towards Allah subhanahu wa ta'ala as well as towards the other believers or in the non-believers and the other creations of Allah subhanahu wa ta'ala. And with this intention only, we always strive in our profession also to upgrade our skills, to upgrade our knowledge. And having such kind of CMEs is a regular part of our DARE organization. And DARE is a group and a platform of all the Muslim doctors where we nurture ourselves, we share the common platform for enriching our Iman as well as our professional knowledge and skills. And we also try to have a unified and a collaborative network where we can support each other and create an atmosphere where we help each other in terms of all that is good and also guide each other and to help each other in preventing whatever is evil. So with this short message, I conclude taking consideration of the time constraint, and we can proceed with the other session. Thank you. Jazakumullahu khair.
Thank you, Dr. Abdul Wase, a senior consultant associated with WHO. Now, moving on to the next topic, it is now my privilege to introduce our speaker for today, Dr. Syed Moeed Zafar. Dr. Syed Moeed Zafar has extensive experience in the field of movement disorders including advanced training in India and abroad. He has worked as a movement disorders neurologist at SciFi Hospital, Mumbai, and has also been associated with Fortis Hospital. He recently completed a fellowship in advanced therapies of movement disorders at Toronto, with training in DBS, MR guided focus, ultrasound, and levodopa infusion therapies. We are truly honored to have him with us today. Without taking much time, I would like to invite Dr. Syed Moeed Zafar to deliver today's lecture. Sir, over to you.
Assalamu alaikum. Jazakallah for the kind introduction. I'm really pleased that and I'm honored to be invited in this forum to speak to my Muslim brothers and colleagues. So I have titled the topic today as Advanced Therapies of Movement Disorders, which is directly related to my most recent fellowship in Toronto. So I would briefly introduce about what are advanced therapies which are available for the movement disorders. And then I will talk about the indications for those therapies and how do we decide which therapy is to be chosen. And then I will talk briefly about the fellowships available in India and abroad for movement disorders. And we'll also give some resources from where we can get further information about the fellowships available and the persons to be contacted to get those fellowships, basically. And then I would briefly speak about advocacy for movement disorders in India. So the advanced therapies for movement disorders consist of deep brain stimulation surgery. On which I will be elaborating in a few minutes. Basically, deep brain stimulation is mainly indicated for Parkinson's disease, which is the most common indication for DBS in India and abroad. Then essential tremors and dystonia. And then infusion therapies for Parkinson's disease is also one of the advanced therapies, amongst which is the levodopa infusions. Among the levodopa infusions, there are two types of infusions: intrajejunal infusions, which are delivered through a peg, and subcutaneous infusions, also called as VLF, so which are subcutaneously delivered. And these infusions are basically pumps which are worn basically. I'll show you. Basically, it's worn over the chest wall or like a belt over the waist, and it can be carried along wherever the patient goes. And the other these levodopa infusions are still not available in India as of now. But the infusion which is available in India is apomorphine infusions. I will also be talking about apomorphine infusions briefly. And then the other advanced therapies for movement disorders, MR guided focused ultrasound, which is also available in India, but at present in a very few centers, few centers in Delhi, one in Hyderabad, and one in Coimbatore. So this focused ultrasound therapy is also indicated for Parkinson's disease and for essential tremor patients. Now, coming to advanced therapies for Parkinson's disease, which are also termed as device-assisted therapies. They consist mainly of neuromodulation, that is deep brain stimulation, and infusion therapies. So device-assisted therapies, in which patients of Parkinson's disease do we consider them? So most important thing is these therapies are only indicated for patients who have Parkinson's disease. So the diagnosis of Parkinson's disease should be certain, and any other Parkinson look-alike should be ruled out first, like atypical Parkinsonism or any secondary causes of Parkinsonism because of space-occupying lesions or strokes should be ruled out before offering these therapies. And amongst the patients who have Parkinson's disease, they should have disabling motor fluctuations and dyskinesias, which affect the quality of life. So for those who are not aware, disabling motor fluctuations and dyskinesias are a complication of treatment, that is levodopa, and also of advanced disease. So as the Parkinson's disease progresses over a period of years, the duration of action of levodopa, which is the main therapy for Parkinson's disease, decreases, and the patient basically fluctuates between good and bad states. So good state is when the patient has good response to the medication and has good symptom control of tremor, slowness, and stiffness, and which is also called as on state. And off state is a state where the medicine levels are low in the blood, and the medicine does not have an impact on the brain, and patient gets back the symptoms of tremor, slowness, stiffness, and gait issues. So these are called as motor fluctuations, and these occur in advanced Parkinson's disease as a result of the progression of the disease, and also because of drug-induced complications, because of levodopa levodopa effects decreases over a period of time. And the other complication is dyskinesias. This is also drug-induced, caused by levodopa, and it is usually seen in on state when the levodopa effect kicks in, which we also call as peak dose dyskinesias. So the dyskinesias are, in simple language, dance-like movements or coriform movements, which can be very disabling, and sometimes it can cause difficulty in mobilization, and in some patients they can even fall off the chair because of the vigorous movements in the limbs. And so these two motor complications, when they start affecting the quality of life of the patient, these patients we consider for advanced therapies like deep brain stimulation or infusion therapies. So this who decides that the motor fluctuations and dyskinesia are disabling? Mainly, it is based on the clinician's discretion, like a neurologist who's treating the patient since many years, and then they know, okay, now this patient is not responding well, even after optimizing the medical treatment, and this patient would need to go for advanced therapy. So it is based on the clinical discretion of the treating specialist. And there is another 5 to 1 rule, according to the Delphi criteria. By 5 to 1 rule, we mean that if the patient is taking equal to or more than 5 doses of levodopa in a day, if the patient has at least 2 hours of off time, that means at least 2 or more than 2 hours the patient spends in an off state where the medication is not working, and the patient has significant disabling of symptoms like rigidity, slowness, stiffness, and tremor, because of which the patient is not able to move. Patient needs assistance to move, and at least 1 hour of disabling dyskinesias. So dyskinesia is again dance-like movements where the patient is not able to do his routine activities because of the dyskinesia itself. So 5 to 1 rule. This is one of the criteria which simplifies the selection of patients for Parkinson disease for DBS. And there is one more tool which is available online called as Manage PD tool. If you type Manage PD in Google, you can go to the website, register, and there is a series of questionnaires where one can fill the questionnaires, and it will tell you whether the patient is optimized on therapy or not. And if the patient is not optimized on therapy, whether the patient can benefit with optimization of medical therapy, or the patient will need advanced therapies like deep brain stimulation or infusion therapy. So this is also a good handy tool to decide whether the patient needs deep brain stimulation or would benefit from deep brain stimulation or any other advanced therapies. So apart from selecting the right candidate, and then finding out whether the patient has reached a stage where he now needs advanced therapies, the other things which needs to be ruled out is there should be absence of frank dementia or uncontrolled behavioral symptoms, because these patients are not good candidates for any type of advanced therapies, especially deep brain stimulation. And again, then we have to tell the patients that they should have realistic expectations. Any of the advanced therapies do not cure the Parkinson's disease. They are an additional tool to improve their symptoms and the quality of life. It decreases the off time, that is the time they spend with their symptoms, and increases the on time, the time in which they have benefit of the medications without where and in which they don't have the tremor, slowness, and stiffness without the troublesome dyskinesias. So the dyskinesias are usually commonly seen when the patient is on. So these therapies would improve, increase the on time, but at the same time will prevent the dyskinesias. So these are the expectations, and this is how like we counsel the patients and the relatives that what they can expect after the deep brain stimulation or any of the advanced therapies. So this picture shows uh, how we do the deep brain stimulation, and depicts basically the electrode being placed in the brain, deeper parts of the brain, and it's connected through a connecting cable to a pacemaker, which is placed on subcutaneously over the chest wall. So deep brain stimulation, in simple terms, is continuously stimulating, continuous electrical stimulation to a specific brain nuclei. Among the common brain nuclei which we target in deep brain stimulation is the subthalamic nucleus, the globus pallidus interna, and the ventral intermediate nucleus of thalamus. So these are the common targets, and they are stimulated through electrodes placed deep in the subcortical regions of the brain. This is a small animation which shows again the same thing, how deep brain stimulation works. So here it shows the pink part, light pink part is the basal ganglia. The dark pink uh, part of in the diagram is the subthalamic nucleus, where these two electrodes are being placed. So they are placed by a neurosurgeon, and a burr hole is done on both sides of the skull, and these two electrodes are placed, and then it shows that the subthalamic nucleus is being stimulated. The connecting wires, and again the pacemaker, which is implanted over the chest wall. So this is how deep brain stimulation looks like. So here I have a small video, which is actually from the institute where I was trained. I think probably I'll have to get out and I have it over here on yeah, so it's over here.
Hey, good to see.
Just a moment.
Hey, how are you?
Hope you can see this.
49-year-old musician Fabio Dwyer has Parkinson's disease.
Okay, so we can actually connect you.
It's hard to tell, thanks to a pacemaker, not for his heart, but for his brain.
Okay.
Now it's about to get a reboot that could change his life.
So now let me stream.
So this, I hope you can see the video and hear the sound. Hello?
Yes.
Yeah. So basically, this video is tells us something about deep brain stimulation, how it works, and it's mainly focused on a latest technology in deep brain stimulation called as adaptive DBS, which so the person, he is my professor in Toronto. So this is a video basically shot on CBC, Canadian Broadcast Network, and it was this patient was featured in the video. So
Now from the brain, and you might feel some dizziness now because I'm going higher. Sorry about and this is the first time you are on an adaptive setting.
We're taking you inside an innovative medical trial at the University Health Network in Toronto, where new technology is offering patients with Parkinson's a more personalized therapy. It's called Adaptive Deep Brain Stimulation, or ADBS, and it has the potential to revolutionize the way we treat neurological conditions, and we're going to show you how it works in real time.
And I'm gonna lower the stimulation slowly. Then I go down to 0 so that there is a tremor.
his symptoms begin to show. Neurologist Dr. Alfonso Fasano is adjusting electricity levels flowing deep into Dwyer's brain. Electricity is the brain's natural language. A device placed in Dwyer's chest connects to electrodes implanted in his brain. It sends out continuous electrical impulses that disrupt abnormal brain activity.
Do you feel anything right now?
I start to feel like a little bit.
Well, let's go a little higher.
Deep brain stimulation eases Dwyer's tremors, but the muscles around his mouth remain stiff.
You're part of this trial now because we're trying to see whether we can improve your speech. So let's have a good recording of your speech now with the standard stimulation. Why don't you tell us what you did yesterday?
A little of a song by the Beatles called Around My Guitar in 3 weeks.
So this is a baseline of your speech.
Dwyer's part of a Canadian trial testing the power of ADBS.
In adaptive deep brain stimulation, the stimulation is given on demand, only when the brain really needs more stimulation or more treatment.
In some ways, standard deep brain stimulation is like cruise control in a car. It keeps a steady speed, but when traffic slows down, you manually need to hit the brakes. Same goes for DBS. Adaptive DBS, on the other hand, is more like smart cruise control. The car slows down automatically. The device senses changes and adjusts.
Instead of just doing the same thing over and over, and therefore causing side effects, it's only delivering stimulation when the brain needs it.
For Dwyer, deep brain stimulation put him back in control. Diagnosed in 2018, he saw his future slipping away.
It was like a big hole, deep hole, black hole was opening under my feet and I was like falling like non-stop. But I knew right away that my career as a musician would be severely harmed.
A career that, strangely enough, crossed paths with Dr. Alfonso Fasano years before his diagnosis. The next time they'd meet was in the hospital. Okay, so now the device is turned off.
Yeah, and that's how it is when I'm off.
In the days leading up to his adaptive upgrade.
Like, that's how bad the shit.
And it just happened almost instantly.
Yeah, it takes like a few seconds.
Dwyer showed us what life without this therapy looks like. It's really remarkable.
I'm very good shaking martinis.
Shaken, not stirred.
Yeah.
When he turns it back on, just like that.
Just like that. Amazing.
Amazing. Remarkable.
It's like 5 minutes shaking. Look like that. I can feel the muscles, the pain in the muscles.
He's hoping the adaptive upgrade will help.
So basically, this is a brief video showing us how a patient can benefit from deep brain stimulation. And I'll just go to the presentation. Okay, can you see my slides again? Hello?
Yes.
Yeah. Okay, so so coming to the infusion therapies. So this picture shows us LCIG, which is also called as levodopa carbidopa intestinal gel. So here this is the pump, which is supposed to basically infuse the levodopa carbidopa intestinal gel, which is there in this cassette. So the cassette is attached to the pump, and here we adjust the rate at which we want the levodopa gel to be delivered into the intestine. So this connecting tube is basically connected to a PEG tube, which is the procedure is done by gastroenterologist, and this PEG tube also has a J tube which goes to the jejunum. And so basically, jejunum is the place where the levodopa is naturally absorbed, and over here by placing the tube into the jejunum, we ensure that levodopa is being delivered directly to the jejunum. And because it is delivered by a pump, it is delivered slowly at the adjusted rate, and it can be delivered for, it is approved for 16 hours. Basically, usually it is used by the patients during the daytime, and they turn it off at night. And by delivering levodopa continuously at a slow rate, it ensures that the patient's blood levels of levodopa remain constant throughout the day, and there is no fluctuation of symptoms. So it improves the motor fluctuations. At the same time, it also improves dyskinesias because it avoids the peak of levodopa in the blood. So levodopa is constantly there, and thereby prevents motor fluctuations and dyskinesias. So the next photograph again is showing some more details about the levodopa carbidopa intestinal gel and its pump. So over here, as I told you, this pump is connected to a PEG tube, and which is again connected to an extension tube which goes to the jejunum, and levodopa is directly delivered over here. So this is one of the infusion therapies which presently is not available in India. But hopefully in coming years might be available, inshallah. Then this is another infusion therapy which is called as Vyalev. The trade name is Vyalev, and it is a subcutaneous levodopa pump which delivers a prodrug of levodopa carbidopa called as phoslevodopa phoscarbidopa. And again, similar to the previous previous pump which I showed you, this is a different type of pump. It looks like this, and it has a syringe inside which contains levodopa, phoslevodopa, phoscarbidopa solution. And again, this is connected to a tube, and here it delivers the levodopa subcutaneously through a small needle into the abdomen. So basically, the patient keeps on changing the site every 2 to 3 days. Uh, and because there can be some local skin reaction if it is kept continuously. So they can use any part of the body which has some fat, predominantly the abdomen or flanks also. Sometimes lateral aspect of the thigh can also be used for this therapy. So this again, the principle is to deliver levodopa slowly, continuously, and thereby maintaining constant levels of levodopa in the blood. And then this is another therapy called as CSI or subcutaneous apomorphine infusion. So apomorphine is the only therapy which is infusion therapy which is available in India. And apomorphine is actually a dopamine agonist, short-acting dopamine agonist. Here, which is not shown is apomorphine pens are also available. So apomorphine advantage is that it acts very quickly. Within few minutes it acts. So if the patient is off, they can inject through a pen. It is similar to an insulin pen, and the patient turns on. That means the patient symptoms respond almost within few minutes, and patient can do the normal activity. But when injected through a pen injector, the duration of action is only 1 hour. So after 1 hour, again the patient will become off. So the indication for subcutaneous apomorphine infusions is when the patient requires frequent injections of apomorphine through the pen device, like more than 5 times. If the patient needs injections in a day, then we would recommend subcutaneous apomorphine infusions. This again works on the same principle of delivering apomorphine slowly, continuously, and maintaining a constant blood level of apomorphine, thereby preventing the motor fluctuations and dyskinesias in Parkinson's disease. It's similar to the YLF pump which I showed you. This is also delivered subcutaneously through a small needle over the abdomen. So coming to selection of advanced therapies for Parkinson's disease, as we discussed, Parkinson's disease should be confirmed. They should have disabling troublesome motor fluctuations and dyskinesias. So if the patient has a tremor which is refractory to levodopa, if the patient has dyskinesias at a very low dose of levodopa, if the patient is young, patient does not have any cognitive or significant psychiatric issues, patient does not have any postural imbalance, falls and speech issues, then the patients are good candidates for deep brain stimulation. Those patients who have high surgical risk for deep brain stimulation are elderly, frail, have contraindications for brain surgery, prominent non-motor symptoms of Parkinson's disease like like cognitive issues, mood issues, fatigue, pain, sleep disturbances, then mild to moderate cognitive or psychiatric issues, and existing speech problems. Because speech problems, why? Because deep brain stimulation can worsen speech problems. And if they have limited access to multidisciplinary care, then they are good candidates for infusion therapy. So deep brain stimulation requires multidisciplinary care, like they need to come repeatedly for programming of the pacemaker. Sometimes multiple adjustments may be needed until the therapy is optimized. They may also need a psychiatrist, a neuropsychologist, and other and neurosurgeons. So if they are staying in a district place where this special care is not available, then infusion therapies might be a good option for them. So amongst the infusion therapies which we spoke of, like levodopa infusions and apomorphine infusions, which among these therapies, which therapies would be the best in what scenarios? So basically, patients who have, I'm sorry for the short forms, the OH is orthostatic hypotension, impulse control disorders, psychosis, and excessive daytime sleepiness. So these, if these symptoms are there, then levodopa infusions are preferred because apomorphine can worsen excessive daytime sleepiness, psychosis, and other symptoms. If the patient has nocturnal akinesia, that means the patient has difficulty in turning in bed at night, and because of which the patient wakes up frequently, then this subcutaneous phospholevodopa, phoscarbidopa is indicated, because this is the only infusion therapy which is approved for 24 hours infusion and can be the infusion can be continued at night also. If the patient has GI issues and prefers a non-surgical infusion therapy, does not prefer a surgery, then subcutaneous infusion are less invasive and that could be preferred over the intrajejunal infusions. If the patient prefers portability and convenience, again, subcutaneous infusions are recommended. If the patient has sudden on and off, then apomorphine infusion could be good because, again, as I told, apomorphine has very fast onset of action. And again, if the patient has no access to multidisciplinary care, then subcutaneous infusions are better, because again, the intrajejunal infusions can have its own complications and may need a gastroenterologist to look into it, basically. Again, if the cost is an issue, then amongst all the infusions, levodopa and apomorphine is relatively cheaper. So that could be the choice. So indications for advanced therapies in essential tremor. So in which patients do we consider advanced therapies? Patients of essential tremor who have disabling tremor, impacting significantly their functional well-being. Inadequate response to the appropriate medical therapies which are available, like propranolol or primidone. And then if the patient is not able to optimize medical therapy because of side effects. So in such patients, we can consider advanced therapies. The advanced therapies which are available in cases of in essential tremor is the deep brain stimulation. Here the target nucleus is ventral intermediate nucleus of thalamus, whether it is DBS or the other therapy which is MR guided focused ultrasound, which I will briefly mention in a while. So again, I would like to show you another video from our institute which shows a patient with essential tremor. Check once more. Okay. I think there is an issue with, yeah, it is now. It's there now. Okay. So this
From his hospital bed,
I would have never been able to hold this or even bring it to my mouth without it spilling all over the place.
the man who has made a career out of capturing big moments in others' lives
So crazy. It's amazing.
can't resist capturing one of the biggest in his own.
And the cool thing is that the pacemaker's not even on yet.
Kirk Neff has just had a 5-hour operation to insert an electrode deep in his brain to disrupt involuntary shakes in his hand called essential tremors.
Thank you. Great. Great. Yep.
2 weeks later, we are joining Kirk for his appointment as a doctor switches on a current that Kirk will eventually be able to control himself through his phone to stop his tremors.
This is the moment, right?
Oh.
We turn this thing on to see how things stabilize. Are you like, your eyes are welling up
I
right
know.
now?
It's funny because you're talking about it, so now you're making me more emotional about it.
What I need you to do is what we...
It begins with a quick test to see how Kirk's hand reacts before the current is on.
Let's go for it.
You can see that Kirk struggles to keep the pen steady in their spirals. It takes everything out of him.
Now I gotta breathe.
Yeah, it's certainly something of
So stressful.
Of course.
The doctor first looks at where the electrode is placed in the brain.
Oh, wow.
This is your brain.
That's crazy.
And this little dot here,
Yeah.
that's the electrode.
Then begins to deliver a current.
Yeah, I feel it now.
Okay.
Yeah.
What do you feel?
Just a little slight, like a, almost like a vibration electricity kind of thing.
The goal here is to deliver just the right amount of stimulation to manage Kirk's tremors and minimize the side effects.
Touch your nose. Touch my finger. Go back and forth.
After a bit of adjusting, you can see the difference just by looking at Kirk's hand.
Oh my God. I feel like I'm in space. Like just, you know what I mean? Like I'm just like hovering. It's crazy. Look at that.
Have you ever seen your hand like that?
No.
That
no.
stable?
No, never.
I don't think I have either.
Like, that's incredible.
Remember that spiral test? Well, he does it again,
Very good.
this time with a lot more control.
Hello, how are you doing?
Good. Good to
yeah, okay, so this was a patient with essential tremor who benefited from the surgery. Then the other therapy which is available for essential tremor is MR-guided focused ultrasound. So this is similar to what used to happen in the past, and still in some centers people are doing. So basically, this is similar to radio frequency ablation or thermocoagulation of a sub-millimeter part of the brain to improve the tremor. So this is called as MR-guided focused ultrasound, in which the patient is placed in an MRI machine, and the patient wears this helmet type of thing, which is the ultrasound device. Around the skull, first there is again a tubing which surrounds the skull, in which the water circulates to prevent heating of the skull. And the ultrasound device basically makes is the around the skull is responsible for shooting a focused ultrasonic beam to the target, which basically the beam increases the temperature, and that part of the brain gets thermocoagulated, or a lesion is created. Lesion is created in the brain, and thereby increasing the thereby improving the tremor. So in this slide, in this slide you can see in the MRI there is the target is ventral intermediate nucleus of thalamus over here, which the surgeon has selected, And the other photo shows us the ultrasonic waves which are being targeted to the ventral intermediate nucleus of thalamus. And once the session is done, first initially they increase the temperature till 40 or 45 degrees Celsius, and there is transient improvement in the symptoms. And they also look for side effects. If there are no side effects and the tremor is better but not completely better, then what they do is they further increase the temperature till 51, around 50 to 60 degrees Celsius, where the lesion becomes permanent and then the tremor completely resolves. And intraoperatively, they again make the patient draw a spiral and see for improvement of the tremor after the procedure. So the indications for MR-guided focused ultrasound in essential tremor or Parkinson's disease tremor is in patients mainly who are older or frail patients who have significant surgical comorbidities and are not good candidates for deep brain stimulation. We prefer these non-invasive therapies. And if the patient has predominantly unilateral tremor or asymmetric disabling hand tremor, patient does not want an implanted hardware and prefers an incision-less surgery and has difficulty or unwillingness for DBS programming. So these are the common indications why when we consider focused ultrasound instead of other therapies like deep brain stimulation. Deep MR-guided focused ultrasound is also being considered for Parkinson's disease patients who do not have significant tremor, like patients who have motor fluctuations and dyskinesias. The target in those patients is paledothalamic tract, which which is lesioned and thereby improving the dyskinesias, the tremor, and the bradykinesia rigidity. So all symptoms can be improved by PTT lesioning. Although this is not being done commonly, it is recently being basically tried for Parkinson's disease patients. Yeah. For patients who have predominantly tremor, ventral intermediate nucleus of thalamus is the target of choice in ET and Parkinson's disease. Now, lastly, indications for DBS in dystonia patients. Again, dystonia patients who have disabling symptoms causing significant functional impairment are good candidates for DBS, have inadequate response to or intolerance to medical therapy, including botulinum toxin. Patients who have primary isolated generalized or segmental dystonia are good candidates, especially. So that's why it's important to do a genetic workup of those patients because it tells us which certain genotypes respond well to deep brain stimulations, like DYT1, which is the classical generalized dystonia, which responds very well to deep brain stimulation. And then patients who have severe cervical dystonia or complex cervical dystonia, which do not respond to botulinum toxin, are also considered for DBS. Selected cases of tardive dystonia respond very well. And status dystonicus is the indication where bilateral GPI DBS or globus pallidal internal DBS is indicated in emergency setting, especially in patients who have life-threatening dystonia. Okay, so this was the briefly about the advanced therapies which are available for patients with movement disorders. Now, coming to the fellowships, basically this is mainly focused for young neurologists or neurology residents who are interested in pursuing movement disorders as their subspecialty. So these are some of the fellowships which are available in India and abroad. And this is one of the important links, which basically is from the International Parkinson's Disease and Movement Disorder Society website, where you can get all the information about the fellowships available in India as well as abroad. And this is basically this is meant. These centers are mentioned on the website because MDS Movement Disorders Society can give also scholarships for fellowships in these centers, and they are recognized by the Movement Disorders Society. But even if someone does not get a scholarship, they can also directly apply to these centers, contact the program directors, and send their CV. Usually, they will ask for a CV and 2 or 3 recommendation letters. So here, at least what I am aware of in India, Bangalore, when I did my fellowship in Sri Chitra, there were only two centers which were offering fellowship in movement disorders, NIMHANS and Sri Chitra. But now there are many more private centers as well. So in Bangalore, apart from NIMHANS, Dr. L.K. Prashant has his Parkinson's disease and movement disorder center, and he also offers a fellowship. And then Sri Chitra, NIMHANS offers every 6 months, takes one fellow every 6 months. Sri Chitra takes one fellow every yearly. In Mumbai, there are a few centers which have started offering. Kokilaben Ambani, Jaslok, and probably I think Global Hospital also offers fellowships in movement disorders. Kolkata, this Institute of Neuroscience, Calcutta is offering. In Kannur, Kerala, Baby Memorial Hospital is offering. Cochin, Aster MedCity is offering this. This is also one of good fellowships because my previous professor, Asha Kishore, she has shifted from Sri Chitra to Aster now. So she's a very good teacher, and this is one of the good fellowships in India for movement disorder. And then Hyderabad, Dr. Rupam is offering at Yashoda Hospital. So these are the fellowships which I at least I know, I am aware of in India. Then in Canada, in Toronto, there are 2 fellowships. One is on movement disorders. It's a 1 year or a 2 years fellowship. Commonly, most of the fellows come for 2 years, out of which 6 months they can choose to be in deep brain stimulation with the deep brain stimulation team. That is the advanced fellowship. And the other fellowship which is available, which I did recently, is advanced therapies for movement disorders, which is focused on deep brain stimulation, focused ultrasound, and infusion therapies. Luckily, there is also because it's basically a neuromodulation fellowship. We also got some exposure on deep brain stimulation in epilepsy, medication refractory epilepsy. Okay, so the other fellowships which are there in Canada, one is in Ottawa, the other one is in London, Ontario, one is Montreal, Vancouver. So these are the other centers which offer fellowship in Canada. The advantage in Canada is that you don't need to give any exam. You just need to contact the program director. You need to send your CV and 3 recommendation letters. Only thing is you will have to wait for 2 years or 3 years. So there is a long waiting period for that, especially if you want a sponsored fellowship. If you want the university or the program to sponsor you, then you will have to wait for 2 to 3 years. The other thing is if you are self-sponsored, or if someone is willing to sponsor you, like a government is willing to sponsor you, which is very rare in India, or a particular hospital where you're working is willing to sponsor the fellowship, then you may get an earlier fellowship because they don't have to pay you. So the waiting period may be 6 months or 1 year. You may get it earlier. So that is the other caveat. So you can try for both the options if the other option is available. And Australia fellowship is there in Sydney. Singapore, National Neuroscience Institute offers a movement disorder fellowship, which is again not sponsored. Unfortunately, many of my colleagues who have gone there, they had to support themselves financially. So this is a bit drawback about the Singapore fellowship, but it's a very good fellowship, and it's close to India, so that is one advantage. Then okay, so before going to advocacy for movement disorder, I would like to show you this website. Okay. to minimize this. So this is this movement disorder website has this visiting trainee grant program, and you can go to this regional programs section, and you can click on any of the continent where you're interested in doing the fellowship. For example, if I click on Asian or Oceanian section, it takes me to this page, and I have to click on this view host sites. So this will tell us in the Asian Oceanian sections where all the fellowships are available. So here you can see that there are 8 centers in India where fellowships are available. So at Amrita, Faridabad, in Kerala, in Hyderabad, Kolkata, okay. And similarly, you can go to Malaysia yeah. So it will tell you the details where the fellowship is available, how long is the fellowship, the contact email address of the program director, and then institution website and other details. So this is a very good resource to find out where all the fellowships are available. You can apply for a grant. Otherwise, you can directly contact the program director and they will tell you the details when the fellowship starts and what is the application procedure and other details. Okay. So as far as advocacy for movement disorders is concerned, we need to create more awareness among the general public about movement disorders, also among our colleagues, the general practitioners about movement disorders and uh, basically when to refer them, mainly for advanced therapies, also among the physicians and the neurologists. So one thing which is, as far as Parkinson's disease is concerned, one thing we need to understand is advanced therapies does not mean the patient has to be in very much advanced stage. So if the patient is very much advanced, if the patient has dementia and other basically contraindicated, by the time the patient is very much advanced, the patient develops a lot of contraindications for deep brain stimulation. So the patient should be referred in time when the patient does not have any contraindications for DBS, as we discussed, advanced dementia, psychiatric contraindications, and at the same time the patient's symptoms should be significantly disabling and not be the patient is not well managed on after optimizing medical therapy. So those patients are very good candidates for deep brain stimulation. Especially we prefer patients who are younger, uh, early 60s or less than 70 years. Elderly patients also, some of them can be considered for DBS if they don't have any comorbidities and no contraindications. They can be considered, like 70 plus, also 75 years patients can also be considered. But preferably we consider patients in who are there in their 60s. The other thing is access to movement disorder centers. Uh, Basically should be provided, like for example, in district places, if the patient if the referring physicians are aware of which movement disorder centers is the nearest and where help can be sought and where the specialist is available, that is an important thing. So considering that, so we need more movement disorder specialists in India so that they can start advanced therapies for people even in district places. That is one thing. So access is for patients for advanced therapies is important. So we need to work on that. And the other thing is affordability of advanced therapies. So presently, the advanced therapies which are available are deep brain stimulation and MR guided focused ultrasound, but mainly. Apomorphine is also available, but it's not widely being used as far as my knowledge is concerned. But deep brain stimulation is quite expensive in India. Many patients who need deep brain stimulation surgery cannot afford it, and hence they have to suffer because of the advanced symptoms. Uh, so especially considering that the government does not support these surgeries, and many of the insurance companies also do not basically sponsor these patients basically. So even if they uh, give some insurance, it is partly funded, not completely funded. So that is one thing which we need to work on, so that at least government understands the disability these patients are suffering from, and they are willing to sponsor these patients. Some of the government institutions like railways or State Bank of India employees uh, basically have seen that they get complete reimbursement. So that is one good thing, but some state governments need to, state and central government need to sponsor these surgeries. So that is one thing which is very important, especially in the Indian scenario. So this is all about my talk, and I would be willing to answer if you have any questions.
Dr.
Thank you.
Moeed.
Yes.
Dr. Moeed,
Yes.
there are some questions in the chat box.
Yeah.
If you
Yes.
are if you are
Yes.
having access, if you
Yeah,
are
sure.
having
Yes,
access
yes.
to it, you see it.
I
Sir,
will
there
stop sharing
are
the
quite a
screen.
few questions. Are there, I mean, are there any sponsorship or insurance companies covering this program, sir?
The deep brain stimulation, you mean to say, right?
Yeah, for DBS stimulation.
Yeah, so DBS basically uh, uh, insurance companies cover, but they some of the, not all insurance companies cover. Some of them cover, but I'm not aware if they cover it completely. They cover only the partial cost. Like if the surgery is for say around 10 or 12 lakhs, they will cover like they will give 5-6 lakhs, and the remaining the patient has to pay out of their pocket.
So, one more question. Are these fellowships abroad, are they hands-on or only primarily an observership, sir?
No, the fellowships are all hands-on. They
Hands-on.
are hands-on, yeah. So observership is completely different. Observership is basically 1 month or 2 months, maximum 3 months, and you just go there and see what they do basically. You don't get to touch the patients. But if you are getting a proper fellowship, that is hands-on training. I can see the questions.
Acha, okay, sir.
See
Please.
the questions. So Atik sir has asked, after DM or DNB postdoctoral fellowship program movement disorder in India, uh, how to get enrolled. Okay. So
In a few of answers you have told in your lecture, you
okay,
skipped
okay.
the few
Yeah,
answers.
yeah. So basically, you basically you just need to contact the program directors, and they will guide you basically. The email addresses are there on the website of the movement disorders. I think I'm not sure if the MDSI website also has some details of the fellowships which are offered in India, but the international, at least the International PDMDS Society website has it, as I showed you. And you need to know when the fellowship starts. So in Chitra, the fellowship starts in January. It's from January to December, and in NIMHANS the intake is twice a year. So you have to apply in advance. So that is one thing. NIMHANS has an entrance for the fellowship. Chitra does not have an entrance. Chitra just has an interview, and then you have to give a research project proposal, and based on that they conduct the interview. Fellowship abroad is hands-on. Okay, this is done. Why you choose double programs? Yeah. Okay, so the reason why I chose to do fellowship abroad is basically, so I will just briefly tell you about my my journey of movement disorders. Why I got interested in movement disorders. Basically, I had passion for clinical neurology, and I was trained in a center in Bangalore, Naran Rudale, where we had only one fellowship, and that was in intervention with Dr. Vikram who did. So, and fortunately, I had the experience of being there in the cath lab, but but I realized soon that it was not my cup of tea, and I was interested in something more clinical. At that point of time, we didn't have any movement disorder exposure or movement disorder consultant in our hospital. Used to go to NIMHANS frequently and attend uh, Dr. Pramod Pal's clinic over there in NIMHANS. Then I decided to do a movement disorder fellowship because I realized that it was one of the most clinically oriented subspecialty in neurology. Then I worked with Dr. Rupam Borgohain sir in NIMS for 3 months, and he was kind enough to teach me about mainly about deep brain stimulation, and he was the one who recommended me for the fellowship in Sri Chitra. Sri Chitra fellowship was very good. Actually, I had a very good exposure. They were very good teachers, Dr. Sham, Dr. Asha Kishore, and there was a good exposure to Botox and deep brain stimulation. But what I realized, even in NIMS and Sri Chitra, that most of the patients which we used to operate on for DBS was predominantly 90% Parkinson disease, or I would say 95% Parkinson disease, and very few dystonias. And the targets which were being used was mainly subthalamic nucleus. Dystonia is definitely very few cases were done during my fellowship, and they were GPI. But I did not have much experience with other targets like ventral intermediate nucleus of thalamus or GPI DBS for Parkinson's disease, and not many off-label indications like tardive dyskinesias or tardive dystonia and tic disorders. So the reason why I did a fellowship abroad was basically I went to Toronto Western Hospital immediately after my fellowship in Sri Chitra in 2017. I went for 3 months as an observer, and I really liked the center, and I wanted to go there again and do a fellowship. So I had applied the fellowship in Toronto Western in 2017, and since I had done a basic movement disorder fellowship in Sri Chitra in 2016, I therefore opted for the advanced therapies fellowship rather than again doing a movement disorder fellowship. And for me, it was a long waiting, because I waited for almost 8 years for this Toronto fellowship, because there were other issues, and then COVID came in between, and then in 2023 uh, 2022 the program director, Professor Alfonso Fasano, promised me the fellowship after 3 years. So meanwhile, I was practicing in Bombay as a movement disorder specialist, and I did few cases of DBS, around 10 to 12 cases of DBS before going abroad for the fellowship. So the main reason why I went abroad was because I wanted more exposure in DBS. I wanted to learn programming of different targets like GPI for Parkinson's disease, and I wanted to see more dystonia patients and other essential tremor patients. So, and Alhamdulillah, I was very much satisfied with the exposure I got over there. So that was the main reason why I chose to do another fellowship abroad. And then apart from these things, the uh, basically research is also one thing which is a good avenue over there, and you get lots of opportunities to do research. They value research very highly over there, and you get 2 days completely free for research. So you get time for research. In India, what I found is we are so busy in our clinical work that we don't get time for research. So this is one more advantage of doing a fellowship abroad, that you get a good number of publications.
Sir, can you please on your video, like only voice is coming?
Yeah, okay. Yeah, sure. No problem. Yeah. Sorry. Yeah, sorry. So, yeah. So, doing a fellowship abroad also gives us good opportunities for research. So that is one more advantage. Okay, so the other question is in general, which program is the most practical to do when we have family and learning obligation, cannot do a prolonged hands-on training? Do you have it? Okay, so I would definitely suggest doing a proper fellowship of at least 1 year, because hybrid programs, 3 months fellowships may not give you sufficient exposure and may not give you confidence to practice movement disorders. Uh, I definitely consider the other things like families, other obligations, all those things are there. But these are like fellowships abroad are paid fellowships. Even in India, these are paid fellowships. Probably you may not earn the equivalent amount as you earn while you are a consultant neurologist. That yeah, you will have to sacrifice on that definitely. But I would definitely recommend doing a proper 1 year fellowship rather than doing a hybrid fellowship or just 3 months observership, because you may get some exposure to movement disorders, but a fellowship definitely gives you a good platform to practice movement disorders, and it's a long-term game basically. And once you have a proper fellowship, people from other specialties or even your specialty would be more confident in referring you patients, because they know that you are properly trained and you have the adequate experience to practice movement disorders. So 3 months observership may be just a starting point. Other one more strategy I would suggest is which worked for me is I did an observership at the same center where I did a fellowship. So because I did an observership, see, getting an observership is very easy. You can just go and do an observership, 1 month or 2 months observership. They will accept you. Only thing is you have to pay a certain amount for the observership, and you have to bear your own expenses while you are there abroad, unless you have a relative in that same city. So that is the thing. But once you are doing an observership, it gives you an opportunity to show your skills, especially in the discussions which happen during the clinic, to show your skills and to show your knowledge to the program director over there. And during that 1 month or 2 months of observership, you interact with the program director, and they come to know you. So, and if they like you, you can apply for a fellowship when you are there in that center for the observership. So, one thing what I would suggest is you can select a particular center where internationally where you would like to do a fellowship, and then you can just email the program director and tell them that you would like to come briefly for an observership. You go there for 1 to 2 months, work with them, get familiarized with them. And the other thing is, when you are there in the center, you know what all things they are looking for when they select a fellow, and you get a lot of information from the fellows which are there in that center. So that is also very helpful for you to get the fellowship. For me, because I was already doing I did an observership over there in Toronto Western. They did not take an additional interview for the fellowship because they already knew me. So, and I just submitted my CV and 3 recommendation letters, and it was easy to get a fellowship. Only thing is, I had to wait for many years because of multiple reasons. So this is one thing you may consider. Okay, and for movement disorders, can we model a patient to how he would respond to
Sir,
disease? Yeah.
which patients are to be subjected to Botox in context of movement disorders?
So Botox is mainly indicated for focal dystonia, when only a particular body part is affected, then or at the most segmental dystonia, where two contiguous segments of the body are affected. In those patients with dystonia, usually we consider Botox. But patients who have generalized dystonia, we do not usually consider Botox. Botox is mainly focal dystonias.
Sir, one last question. Sir, can DBS be done in patients who previously underwent failed MR-guided ultrasound?
Yes, so that can be done. Definitely, this is a very good question. So patients who have failed MR-guided focused ultrasound, deep brain stimulation can still be done. What they do is the surgeons usually use electrophysiology before implanting the electrodes. So they try to record uh, from the cells where they are supposed to implant the electrodes, and if the cells are active, then they go and put in the electrode. Or they can use a different target. For example, if MR-guided focused ultrasound was done for dystonia and GPI was selected as a target, and that focused ultrasound GPI or PTT was selected, and that focused ultrasound procedure has failed, then they can consider subthalamic nucleus as the target for DBS. But other way around cannot be done. If the patient has undergone DBS and the DBS has failed, then the patient cannot undergo MR-guided focused ultrasound, because focused ultrasound basically heats the area of the brain where it is focused, and that can cause heating of the intracranial electrodes. So patients who have undergone DBS cannot undergo focused ultrasound. Yeah. So any other questions? Patients who previously underwent failed. Okay, this is done. What kind of profile required to accept fellowships and I think these I've answered. More awareness in the response resistant post-encephalitis.
You answered
Okay.
all, sir.
Yeah, so one thing is, response in resistant post-encephalitis and post-hypoxic injuries. So, so post-encephalitis and all secondary dystonias. In some secondary dystonias, we can definitely offer deep brain stimulation with the caveat that patient may or may not improve significantly. Like we used to do deep brain stimulation for cerebral palsies and indications like Lesch-Nyhan syndromes, because where there is a patient is significantly disabled, we can still consider doing DBS, explaining the patient's relative that certain aspects of dystonia might improve, some aspects might not improve. So usually the dynamic component of dystonia improves very well to DBS. Fixed dystonia usually does not improve to DBS. And then axial dystonia usually does not respond very well to DBS. Limb dystonia responds well to deep brain stimulation. And again, in the limbs also, proximal dystonia responds better than distal dystonia involving the fingers. So dexterity may not respond very well. Fine dexterity may not recover, but proximal movements like ballistic movements of the shoulder and the elbows may respond better. So all these things we need to explain the patient's relatives before considering DBS in off-label indications or secondary dystonias. Yeah. Anything else?
Sir, are DBS electrodes MRI compatible?
Yes, DBS electrodes are MRI compatible. 1.5 Tesla MRI compatibility is there, but now this Boston and Medtronic are also coming up with 3T, have come up with 3T compatible DBS electrodes. So they are MRI compatible, but only thing is we need to turn off the stimulator, and we need to change the setting of the DBS stimulator before doing the MRI. But MRI can be done.
Thank you for the excellent and insightful session, sir. It was very informative.
Yeah, thank you so much. I am glad that it was helpful. Alhamdulillah.
Alhamdulillah. We now come to the concluding part of the session. I would like to request Dr. Atiqur Rahman, sir, senior consultant, to deliver a vote of thanks.
Assalamu alaikum warahmatullahi wabarakatuh. We need highest scientific temper, virtuous people and institutes with high moral values and ethics who can directly influence the healthcare. So I thank Dr. Moeed Zafar for giving very good insight to fellow neurologists and motivating the young neurologists for subspecialty work. I thank all the participants for making successful interactive sessions. And I end with a dua. Allahumma inna as'aluka ilman nafi'a rizqan halala amalan mutaqabbala. Sadaqallahu al-azim. Jazakallah khair. Thank you so much.
And I would like to just tell fellow neurologist and whoever is interested in movement disorders that please don't hesitate to contact me. I can share my contact number on the chat. This is my WhatsApp number, and I would be very happy to guide anyone who is willing to pursue movement disorders. Because personally, I have struggled a lot, and I have gone through many things. Like I have consulted many people. Some people guided, some people did not guide well. So I would be very open, and I would be very happy to guide any of our brothers and sisters who are willing to pursue movement disorders. And I wish you all the best. Inshallah, keep on trying. If you are passionate about movement disorders, please keep on trying for fellowship. Inshallah, Allah will help you. Inshallah.
Thank you, sir.
Welcome, welcome. Assalamu alaikum.
Walaikum salam, sir.